Okay, hi everyone. This is Lola. I'm the coordinator of the Harvard and Beth Israel Deaconess Medical Center site for the New England Mental Health Technology Transfer Center. Please feel free to introduce yourself in the chat box if you would like. And now I'll just go over a few housekeeping items before we begin. Next slide, please. So participant microphones will be muted at entry. If you have questions during the event, please use the chat. This session is being recorded and it will be emailed out to all participants once it becomes available on the website. If you have questions after this session, please email newengland@mhttcnetwork.org. At the end of this month, we will send you a certificate of completion that you can then submit to your particular board for continuing education credit. Please contact ifisher@c4innovates.com for more information on CEs after the event. Next slide, please. This summarizes our MHTTC acknowledgements. Next slide, please. The MHTTC network uses affirming, respectful, and recovery-oriented language in all activities. That language is strengths-based and hopeful, inclusive and accepting of diverse cultures, genders, perspectives, and experiences, healing-centered and trauma-responsive, inviting to individuals participating in their own journeys, person-first and free of labels, non-judgmental and avoiding assumptions, respectful, clear, and understandable, and lastly, consistent with our actions, policies, and products. And with that, I'll hand it over to Kelsey for some introductions.
Sure, thanks. And yeah, thank you for introducing yourselves in the chat too. Great to see where everybody's coming from today. And thank you to Michelle for joining us today. So I'll do a quick introduction for Michelle. So Michelle West is the director of the Program for Early Assessment, Care, and Study, also known as PEAKS, which is a clinical high risk for psychosis program in Aurora, Colorado. She's also an assistant professor in the Department of Psychiatry at the University of Colorado School of Medicine. So Dr. West is a clinical psychologist who specializes in the assessment, treatment, and research for young people who are showing possible early signs of risk for psychotic spectrum illness, and also has worked very closely with our CEDAR program here in Boston around many of the things that she's going to talk about today. But so today's focus is specifically on risk for harm in early psychosis and some strategies to work with folks who have that in the picture. So thank you, Michelle, for being here. Really great to see you, and I will hand it over.
Thank you very much. I appreciate you inviting me, and seconded. Thanks for everyone introducing yourself in the chat. It's fun to see where everyone is from. I'll be doing my best to keep an eye on the chat while I'm talking, although I know sometimes that's tough. And yeah, we can get started. I have no relevant disclosures for the content of this talk. Briefly touching on agenda. So I'm going to go through a brief overview of harm risk, which includes both suicidality and self-injury and early psychosis. I'm going to introduce a disguise case example and go through some assessment and therapeutic tools for this overlap in working with young people. And then I'm hoping that we'll have a discussion, and people might have their own questions about folks that they're seeing and trying to help who are experiencing this overlap. In terms of terms, so I wanted to quickly introduce a few here. Likely folks know these, but clinical high risk for psychosis, I might abbreviate in the presentation as CHR, is signs of risk before folks develop a first episode of psychosis or the first time psychosis symptoms get really strong. And then first episode psychosis is that first period, and variably defined after that, when psychosis symptoms get really intense. Then we have self-harm, which is intentional injury of self. This is often seen as like without intent to die, although that can get messy and complicated, sometimes also called non-suicidal self-injury. And then a suicide attempt is intentional injury of self with intent to die. And sometimes people will like partially intend to die or have like mixed intent or unsure intent. So I'm stating those here. Sometimes there's other terms people use variably, but I thought I would mention those at the outset. we're going to be talking about both of those areas today. I will say before diving into some overview here that you can spend hours and hours and hours talking about harm risk. And I'm guessing that a lot of folks on this call have done a bunch of trainings on harm risk in general, and possibly psychosis specifically. So my purpose here is not to go into intensive detail about all the harm risk theories, but more just to give a bit of an intro, an overview quickly. And then I'm happy to go back and answer questions if it turns out that folks have like follow up on these. So there's a ton of like clinical writing and literature and research on general theories of suicide risk. So you can see a small sample of the theories here, which are the ones that I often think of. So the interpersonal theory of suicide, DBT's theory, and the cognitive model. There's also a lot of attempts to gather and organize different suicide risk factors. I'll show those in a second. Overall, my impression from all of these is that it's going to be a bit overwhelming. Like there's lots of this. And then it can make it a little bit stressful and overwhelming to consider what to do in the moment with a particular client that might be exhibiting like some or all of the signs that might be described in these models. So I'm going to be focusing a bit more on like clinical decision making rather than overviewing theory details. But these are examples of attempts to organize and list suicide risk factors. This is just one of them, and there's a lot out there. SAD persons is this acronym, which I can't decide how I feel about exactly, but it's not an exhaustive list. I've often found this theory to be a helpful one. So there's some attempts to try to like organize or integrate different models and theories of suicidality. This one is the 3 steps theory. They talk about how like in suicidal ideation results from a combination of pain plus hopelessness. Step 2, they talk about further escalation in suicidal ideation if a person feels really disconnected or like a burden to other people. And then step 3 is when ideation progresses to attempts through a combination of factors that can make it more likely that people will act on ideation. So that can be things like having a suicide occur in your community. So there's some like modeling, so capacity to attempt suicide, like things like self-injury would go into that category, etc. It mentions imminent risk here. So I'll talk about that in the context of, there's this conceptualization of ASADs, or acute suicidal affective disturbance. It was at one point, and I'm not updated on this one, but considered for a DSM diagnosis. But the idea is that this is like a quick escalation in suicidality. So it can be like very quick in the context, in the sense that like providers may or may not know that this is happening or may not be able to catch it, because it can like intensify very rapidly, rather than like, you know, months and months of thinking about death and dying. Like over hours. Includes both marked or one or both of marked social alienation and self-alienation. So seeing like really strong negative thoughts about yourself, that these are hopeless to improve, and then 2 or more signs of over-arousal. So things like insomnia, agitation, irritability, etc. And this is versus chronic suicide risk, where like over months or years, signs of suicide risk exist. And so those are things like thoughts of death and dying, etc. Shifting slightly to thinking about how early psychosis comes in. Just broadly, my message in this section is that harm risk is really high in early psychosis groups, and that makes it really important to be talking to folks that you're seeing about harm risk in this clinical population. I'm guessing a lot of folks a lot of folks that are on this call and based on the chat I'm seeing are working in early psychosis, like clinics or research teams, et cetera, with a variety of different roles. So it's really important to be considering suicide risk in this population. I'm not going to read through all the details on this slide or these slides, but this slide is talking about the risk of suicide attempts and suicidal ideation in early psychosis samples, both clinical high risk and first episode psychosis. So this and the second to last bullet talks about how like 80% of female clients and approximately 50% of male clients at clinical high risk endorse suicidal ideation, and similarly high rates for first episode psychosis. Large percentages of folks attempt suicide as well. In terms, similar for self-harm risk, in adolescence, like self-harm is seen as being one risk factor for suicidality, in addition to also being a way that people harm themselves. And for both clinical high risk and first episode psychosis, self-harm behavior is extremely common. So you can see the really high percentages there. So also important to be considering when you're working with folks. It's also helpful to think about how psychosis may or may not, psychosis symptoms themselves may or may not be related to harm risk in young people. So in one way, suicidality might be a reaction some people have to the experience of having psychosis. So sometimes people make meaning of psychosis in hopeless ways. So like expecting symptoms to worsen, expecting psychosis will interfere with their future goals and how they imagine their future. And so those features like leading to wishes to die. It can also, psychosis can also impact social lives in various ways. So one thought that I've heard before is that like psychosis makes me a burden to other people. People are likely to think negatively of me because of psychosis. And so those things can contribute to thoughts about dying and hopelessness. For some people, harm content can actually be a part of the psychosis symptoms themselves. So as one common example, command hallucinations to harm oneself. Violent related content is pretty common in psychosis symptoms. So in this one study, about 71% of an early psychosis sample had self-directed violent experiences as part of their psychosis. So that can be another way in which harm and psychosis can directly relate to each other. It's also possible for a person that has psychosis to have harm risk features that are completely unrelated to the psychosis specifically. So can be like triggered by stuff like arguments with your family, like depression and despair, etc. Thinking about the depression component, it's really common that folks with psychosis have co-occurring depression, and there is evidence in research that it appears to interact to increase risk of harm for people with psychosis. There's some stats here about how many people at first experiencing first episode psychosis had a depression episode. It's very common. And in longitudinal research, there's evidence that the overlap of first episode and depression impacts suicidality. Let's see. And also in clinical high risk research, very common that folks experience depression, and depression is a significant predictor of future depression and also self-harm. I also like to think about suicidality drivers. So these are things that for like very individual, but for a person might contribute to desires to die or to injure oneself. A lot of research so far looking at suicidality drivers has been with first episode psychosis, and trying to see if there's anything specific in FEP groups that are drivers of suicide. So they've talked about factors that are really common just in general, I would say, but hopelessness, self-injury, prior history of self-harm, suicidal ideation, etc. A couple like specific ones. So some research has shown like longer duration of psychotic symptoms may be a driver of suicidality, although that's not found in all research. And then insight is a complicated one. So awareness of your psychosis symptoms. Sometimes that's something that we're aiming for people to develop in our treatment, and it also does seem to contribute actually, and for some people, to suicidal ideation. So it is helpful to keep that in mind. Also social disconnection and feeling like a burden may also be a driver in this early psychosis population, according to some studies. All right. Maybe I'll pause really quickly and see if anyone has. I'm also like curious from the audience, like how much we have discussion in these presentations. I haven't joined you in a while, but I'm happy for folks to chime in with questions. And I thought I'd pause really quickly here because next I'm going to dive into talking about some assessment tools and therapy related tools that I found helpful. But I want to make sure there's no questions about the general setting the stage part first. Sure, Margaret, I see your hand up.
Michelle, only because I think we should have lots of interaction. Otherwise, I would just stay quiet. You're doing a wonderful, this is fabulous. I love the way you've pulled all these pieces together, and it's really, really helpful. The one thing I just wanted to add to was that the acute suicide affective disorder that you were talking about, where people like have a rapid, one way that it's helpful is if you have someone that you're working with for a long time who has pretty persistent suicidality, it helps you notice a change and know that you have to sort of move in and adjust. So that I just wanted to elaborate on that.
Yeah, I definitely agree.
So, but this is fabulous. Thank you.
I would also add that if it happens to be the case that you're working in kind of a crisis setting, et cetera, and you're like, yeah, with a person that's like, I think about death and dying all the time, and then you are able to note a change based on their description, it's like relevant there too, I would imagine.
Yeah.
Although I have never worked in the ED before. It's like talking to people that have. Very true. Any other questions or like thoughts people want to add? Well, feel free to chime in. I am attempting to monitor the chat. So let us dive into assessment tools. At least, I'm cracking up at this. It's like sometimes I put this in the therapy section, but it's also relevant more broadly to assessment, so relevant to both. I like to consider clinician level variables. We're spending a lot of time focusing on and talking about the experience of the young folks that we may be seeing. And it's also helpful to note that we are humans in the room talking about harm risk. You know, people might vary on this sometimes based on how much practice you have, but a lot of people find discussing suicidality and self-harm pretty difficult. So it makes us feel anxious or like distressed at various ways. And that can give us the urge to avoid talking about harm risk. It is also helpful to keep in mind that clinicians, as much as we might try and attend, you know, webinars like this, et cetera, we can't actually predict who will die by suicide. And no one, except for the young person, can prevent suicide attempts except for the client. It's fairly common that people, including young people, do not communicate suicide intentions to providers. There's several research studies on this fact. It's also helpful to keep in mind with all of this that both underreacting, so not paying attention to harm risk at all, and overreacting, so as an example, like sending folks to the hospital when that level of intensity is not clinically necessary, like both of those directions can have problematic consequences, as described here. And also, it's really hard to like calibrate what level of reaction is appropriate, definitely in this context of talking about stuff that can be really difficult. So I like to keep that in mind, and also encourage folks to, seek support and consultation from team members and as appropriate in your context. To one, make sure that you're not worrying alone, and two, like check to see if there's things that you've missed or things that you could try, etc. Also in that context, it's really useful to have evidence-based guides for considering both assessment strategies as well as treatment strategies. However, before I dive into like assessment details, I always find it helpful to have a person or people in mind when we're thinking about strategies. So I thought I would describe a de-identified and described young person. So let's imagine we're seeing a client, Lori. I'm going to think of seeing this person in a clinical high-risk clinic, which is where I work. And likely she has a variety of things in common with folks that are in a first episode clinic as well. So Lori is a 16-year-old white heterosexual cis female. She's had episodes of moderate to severe depression, including things like sadness, numbness, really persistent negative thoughts about herself and thoughts that other people dislike her. Her attenuated psychosis symptoms include auditory hallucinations varying between like whispers, hearing her name called, and then negative comments about her, and also at times comments that she should injure herself or die. She also has visual experiences like seeing shadows and suspicious thoughts, so that people might be watching or might want to hurt her. These can be like strangers or sometimes like specific types of people. And then over the past 2 months, she's had an increase in suicidality that has caused stress to her and her family, so parents and siblings. So she had her first instances of suicidal behavior. She's had ideation for several years that comes and goes, but first time she started to act on them. So she took a non-lethal dose of pills with hopes of dying, and then she told a parent about it. And then in a second instance, she was in the bathroom preparing pills to take, but a parent heard her and interrupted her and like talked with her for a while and then had her go to her room. This next part describes a bit of the background more generally. So persistent suicidal ideation with wishes to die in moments of distress. These vary in frequency, really kind of varies co-occurring with her mood. And then often she does seek help when she is feeling a lot worse like this, but there have been some instances of her not seeking help from, for instance, her parents. I am wanting to pause because I feel like there's a couple comments in the chat that I might want to. Questions about how frequently questions are answered honestly by clients that we see. I was curious if, and James, anything that you would want to add to your question here?
No, not really. I just think you bring up a great point, and I echo the sentiment of previous speakers. This has been fantastic so far. We know that our reliability in assuming and guessing is just that, right? We don't have a crystal ball and we can't tell. But when we do ask and we do break that barrier, and I understand how loaded a question this is, but when we do directly ask our clients about suicidality, do we have any semblance of how honest they'll be with us? And I think the only other thing I'll add is, do you have any guidance for what we do when we think our client is lying to us when they downplay or reduce their likelihood of suicidality?
Yeah, that's a good question. I'm pondering whether to delay answering part of it for a second from now. But I do think kind of considering asking, I do think that there's a lot of things that weigh into whether the person's going to choose to share their experience honestly versus not. And those can be both clinician variables, so things about you and how you're asking it. So things like asking a person, you don't think about suicide, do you? And the person's like, no. It's like asking leading questions, or seeming really freaked out by asking. Those might be some clinician variables that might weigh into whether this person wants to share with you. It also can be like individual variables. So like things about whether or not they trust you. You know, some young people have told a prior provider that they've thought about dying and then been sent immediately to the hospital, and they're like, well, I'm not going to do that anymore. And so sometimes it can be fears of how the provider might react. It also can be like other sorts of considerations, like, you know, I don't deserve to seek help because I'm so terrible. So you don't share what your actual experiences are. So a lot of kind of concerns and considerations related to the young person might also contribute. I do find that a lot of people do describe these sorts of things to me. And also I've worked with a lot of people who you learn over time, like, oh, actually, yes, you have. It's like, I know I asked you when I first saw you. And I learned later after working with them that they have had some experiences related to either thinking about death and dying or making attempts that they haven't told me before. And I think that's just a part of seeing people for treatment, is you are not necessarily going to get the full picture early on in working with people. And I think you just keep that in mind, and operate with that assumption that we can act based on what we know, and do our best to increase our clients' willingness to trust us with information. Sometimes if I suspect a person is being secretive, I kind of talk about, it's like, I know, and like basically validating like secrecy urges. It's like, I know like a lot of things are tough to talk about with a new person or with an adult or whatever. And, you know, all sorts of things might make people want to like keep their mouth shut about parts of what they're experiencing. And sometimes you like see young people kind of smirk at you or like kind of give you a little bit of an indication that maybe you might be onto something there. And sometimes people become willing when you kind of call it out like that, but not necessarily. But I do think like normalizing the secrecy urges and that's a thing that you're aware happens, like that can have some amount of helpfulness. And we can probably find a lot of additional things we could say on that topic, but that is a good question. Let's see. I do like to consider from the audience what for your practice or your program, if you have a go-to strategy for harm risk assessment. It is advised to use evidence-based measures of suicidality, either as part of your intake process or a tool for ongoing treatment. There has been an increased urgency and effort to assess for suicidality in healthcare. So some like primary care and in kind of broader clinic systems, you see suicide risk measures being integrated in varying levels of success into healthcare. So I listed a few here. Probably the one I see people using the most often is the Columbia. There's like a ton of different versions of the Columbia, but this is a brief self-report measure of suicide risk and can prompt further screening. And then there was a few others here. The last one, there is a DBT assessment tool that's very, very thorough. And I haven't actually used the whole thing with a person before, even though I was on a DBT team for a bit. And we'll talk a little bit more about the CAMs in a little bit. But anybody feel like chiming in on like what your crew uses for suicide risk assessment? No problem. Yeah, that makes sense. Yeah. So it sounds like kind of folks chiming in. Usually the Columbia. I hear you. Us too. Sometimes in child systems you might see another one. I'm trying to remember what our children's hospital uses. But the Columbia is a very commonly used one. the safety. Is a safety a child? Or maybe
It's more a process. So it cues you to ask about suicidal ideation, behavior, risk factors, mitigating factors, and then draw a conclusion.
Yeah.
So it's more structuring the process.
Yeah. Okay, cool. Thank you. That's helpful. I was like, I've vaguely heard of that before, but I wasn't sure. In terms of, so those questionnaires are, measures you can like send to people. I do think the utility of them does vary. Does vary based on how you address them in a clinical interaction. So I think that they tend to be more helpful if you talk to people about them. As an example, people often find questionnaires annoying. I know people that will fill out questionnaires. Like we have one that's like a general quality of life measure that has a harm risk item in it. And a good number of my clients find that questionnaire very annoying and they just click no to everything. Or I've had people that click yes to everything, including the harm risk one. And so talking to people about self-report measures is usually useful. If you were and typically these measures are designed to be a screening tool that you then ask follow-up questions about if warranted clinically. And some considerations about clinical style. I encourage folks to be direct, don't avoid, and have a calm demeanor. Typically, you're wanting to start with general questions and then get more specific if the person is endorsing things. Here's a list of, I think I have a few different versions of listed here, but trying to get timeline and you're trying to get content of experiences. So things like ideation, urges to act, actions, and details related to the most relevant experiences. As a point on actions, so there's research showing that if a person has made any past suicide attempts, so like one or more, the likelihood of future attempts goes up substantially. So it is very important to know whether your client that you're seeing has a history of attempts. And then we'll be talking a little bit about acute suicide risk versus non-acute as we go through in more detail. Here's some sample questions that I commonly ask people, which I'm not going to read through. Also, I'm happy to send slides to people if that's a thing that people do in this context. And then you want to get a sense of the person's plan, their intent, and their means. And means is particularly awesome. I'm happy to. I can send to Kelsey, and then Kelsey can distribute.
Yes, yeah, we'll post it on the web link with the recording.
Okay, cool, thank you. Let's see. Means is and access to means is particularly important to gather information about, especially if a person is exhibiting higher risk for self-harm. Brandon, I see hand raised.
Yeah, I was curious about what you had just shared about the risk of a future attempt being much higher if someone had made an attempt. And I was curious about the threshold for that. Like, where do preparatory behaviors become an aborted attempt? And like, so for example, what I would think of it as an aborted attempt would be a client who maybe ties a noose, puts it up, looks at it, and then decides, no, I'm not going to do this right now. Does that count as sort of what you would think of as one attempt indicating future risk, or is it not necessarily because they did abort partway through?
Yeah, I think that that's an excellent question. I wouldn't call that an attempt, although I would be definitely much more worried about that person than a person that's never done any behaviors towards dying. But I think the cutoff is if you have made an attempt rather than preparatory behaviors. It's kind of, I would say the more challenging gray area is when people have started an attempt that's then interrupted by another person. Because for that person, you're unsure if they would have like chosen to remain alive on their own, or if they would not have, like if somebody hadn't interrupted them. But that's like all of those folks I would be more worried about than people that have not had any behaviors towards dying. I'm trying. Was Elizabeth, was your hand up next or Drew? Okay.
Yeah, thanks. I had a question about means. So I recently asked someone about means, and I didn't have any concerns, but they brought up a really good point that no one had ever mentioned before. They're like, well, I have kitchen knives. You could consider those, you
Yeah.
know, weapons. And I was like, yeah, you're right. So I was wondering, when you ask about means, should we be asking about specific things like a gun? Because I do mention weapon. Or the way that I try to kind of describe it is something that you're trying to use to hurt yourself specifically, because we all do have kitchen knives. I mean, every household has them. So I was curious about if you or others have had maybe a different way of expressing to get more information on means, because people have pocket knives, Swiss Army knives, you know, so many different things that are household items that can be used for planning a death.
Yeah, that's very true. And I think it is 100% true that everyone always has access to means. It's like everywhere. You could be on your bed and try to fall on your head in a way that like injures you seriously. It's like you can't, it's fully impossible to eliminate means. Even in the hospital, like the hospital does a pretty good job of mostly eliminating means, but even there it's very difficult. Or it's like it's not impossible for people that are very determined to find ways to die. And so typically how I think of it is like, you want to go after things that are likely to cause serious injury very quickly. So guns that's why that's the number one, is like folks that are at a higher risk for suicide, like removing access to guns. And then the second is like, so this is why you want to gather information about what the person is thinking about and planning, because those are the means you want to go after. There are a lot of people have like consistent ways that they think about suicide. There definitely are people that think about dying in like every way imaginable. So that gets a little bit more complicated, but I think if you have a person that's like, describes a plan of like cutting themselves and then drowning in a bathtub, you want to try to remove as much access to like big sharp things as possible. For a person that's talking about hanging, like removing access to ropes. For someone that's like wanting to drive off a cliff and do have access to a cliff, like for a period of time, like planning for them to stay away from driving. So you're trying to remove access to means that the person is like thinking about consistently and has access to, with the awareness that you are not able to eliminate means of dying. This is one of the reasons why we can't predict who will die by suicide, because all of this, one, involves a person to be willing to tell us, and two, like things can happen that we can't actually control a lot about what happens when people are, you know, on their own in the world. It's like people have the power to make their own decisions. I do often think of it, you know, when people are collaborating with you to reduce their own access to means, that's one way that they're taking a step towards like choosing to stay alive. And I do feel better about that in the context of seeing people for outpatient treatment. I think Drew was up next.
Yeah, and I want to be sure we're able to get to all the content you plan. So if you want to save the answer to this question later, that's totally cool. When thinking about, you know, not underreacting and not overreacting, and like chronic risk and acute states that can come up from time to time, like often between sessions, you know, I've like heard different philosophies from different people. Like if someone reports a time like in between sessions where, you know, they did have like acute and like active ideation and maybe took some preparatory steps and then eventually aborted. You know, some folks say like that's an immediate like have them go to the ER and be evaluated. You know, other folks have had like different perspectives on that, and I'd like to hear your thoughts about how to approach those kind of like tricky in between session times.
Yeah, that's a great question. I certainly have heard a lot of situations like that also. I think definitely for me, part of it depends on how the person is participating in session and like and planning with you to stay alive versus not. I might save part of that question for after we've gone through a few different therapy strategies, because it's super relevant to that. For me, I think if a person is willing to review the incident where they started to make an attempt or prepare, etc. Like review it with me in detail and like plan strategies to try. I am unlikely to send people to a hospital for that. A lot of times, a lot of the folks that I work with where this has happened in between sessions are thinking about death and dying a lot. So if I were to do that, I would be sending my client to the hospital every single session. And then why would that person bother talking to me anymore? Unless I super like going to the emergency room, which they sometimes people like that, but it's pretty rare. It's like that person is pretty unlikely to want to talk to me further. So that's kind of my inclination, but I certainly like, you know, those sorts of things are anxiety provoking to hear about. And I don't judge providers for sending folks to the hospital in that or to the ED in that context. I would tend not to, though, for myself and my own decision making, but and Sarah, I will answer more of that question when we go through a few strategies also, though. Sarah.
Hi, I'm Sarah. Good to see everyone. I just wanted to throw a little like kindle to the fire. I don't know how like there's not much of a question, but just with means for like more conversation that like off of everything I'm hearing, I wanted to provide something that I try to use when I work with peers, and also like just through my experiences, which aren't that much with like visits to anywhere because I was trying to die, but like definitely lots of suicidal ideation and stuff. I've found it helpful to label like self-harm or injury when working with others as sort of any other compulsive behavior and kind of long-standing complex coping mechanism. And with the secrecy thing, I think is interesting also, because what comes up for me is like witnessing people go through like a huge drug dependency time or years or however short or long it is, and approaching and like someone's maybe not ready to like stop using just yet. And that's been an interesting way for me to, with some pause, approach conversations with peers or friends who are like going through a kind of critical moment with their life. And yeah, I think leaving room, like I enjoy talking about like death as it means to like different people and families and cultures and whatever. But I also think, yeah, anyway, it's not like exactly what like the purpose of this is about, but it felt related in a way, just in terms of like vantage point when like approaching conversation and stuff.
Yeah, I think that's very accurate that like people use self-harm for a reason. It's like most of the time, like humans are not doing stuff without any reason whatsoever. And self-harm, like typically it quickly makes people feel better, or they've even if it's briefly, it's like in moments where you're feeling really terrible, it can quickly make you feel better, and then that makes it like hard to not do it again. As like anything as humans, it makes us feel better, or gives us some relief when we really desperately want it. It makes sense we would do that again. Yeah, I think that you're fully right there. I'm pondering, I wanted to at least touch a bit on some different therapy strategies. So I've introduced them. So I might shift gears to that really quickly. And I'm aware that there's a few things in the chat that I do want to talk about for sure. All right, so shifting slightly to kind of strategies for intervention. So sometimes if you have a person who you have in session with you, and you're observing that you're really worried that they will attempt to end their lives prior to you seeing them again. and sometimes this is a kind of the space where you end up in with some folks that are really struggling right now and thinking a lot about death and dying. This is kind of the decision point. Is like, can we get to a place where you can stay alive until I see you again? And optimally, you want to negotiate for, you know, a longer period of time than that, but sometimes that's where you are. Things you want to like plan if the person is like willing to plan with you, or include other like supports with them in planning to stay safe until then. So here are some considerations there. So reducing access to means, identifying strategies to use when people are particularly intensely struggling or particularly wanting to die, and as much as possible, including the person's support system, like whoever the person identifies that to be. That might be family members for some people. I've worked with some people who are not willing to share this sort of information with their family, and for some folks it's their friends or their significant other. And then for folks where that is not the case, then arranging for the hospital. And it is helpful to reflect for yourself as a clinician, like where your line is for when you're recommending a person go to the hospital. And optimally, you want to be talking to your clients for whom this is relevant, like what you're thinking about and what their point is where they would want to go to the hospital, like before kind of a crisis moment like this, and you want to know your clinic procedures for arranging a person goes to the hospital, etc. I know for me, I have a pretty high threshold for what I'm comfortable with before I arrange, like, or before I recommend a hospitalization, because I think a lot of times the hospital doesn't super help people feel better. It can be a rupture in the relationship. A lot of times people go to the ED and then come immediately right back out to me. And sometimes in the hospital, they are only there for 3 days and then they come back out, and sometimes they're doing better and feeling better. And sometimes they are struggling just as much as they were when they went to the hospital. So I really only think of it as a, you know, if things are going like so badly that I'm worried I won't see you again, then this is what I'm thinking about. However, I'm aware that not everyone has that same kind of decision making, and each clinician, I think, is encouraged to think about this for yourself and to decide what your own boundary is for hospitalization. In terms of non-acute suicide risk, so this is where we are most of the time. Sometimes we're teetering on the edge, and a lot of the time we're in the, like, you think about death and dying a lot, or at least a little bit, and we're working on that as an outpatient treatment target. One is like consistently assessing for factors that for this person, you know, contribute to harm risk, or there are signs that they're struggling more, and then prioritizing treatment targets collaboratively with the client, like thinking about which things are key for you. We'll talk more about the CAMs in a second, but they talk a lot about targeting drivers of suicidality and then enhancing strengths and coping skills. Some considerations are that engagement and treatment is really important at this stage. We are trying to enhance, so I've talked about reducing means a lot, but also enhancing social connections, practicing and reinforcing skills, reinforcing cultural and religious beliefs that encourage life and discourage suicide when that's relevant for some people, and highlight hope for improvement while also validating that the person may not be feeling hopeful right now, so you might not believe me, and not minimizing the person's distress. Sometimes in the context of, like, it's upsetting to sit with somebody that's really struggling, if they're being fully honest about how they're feeling, and telling you how terrible they feel. It doesn't feel good. So sometimes people have the urge to like reassure, or minimize, or kind of like communicate in some way that it's, you know, it's not that bad, we can handle this, and being aware that that is a minimizing reaction that you might be doing for your own benefit, and it may or may not be helping this person, is helpful to keep in mind. I'll touch on, I might ask this in a second, and I think I might have this in here in a couple different places, but I have a few different like strategies that I pull from when I'm seeing folks where suicide risk is a large treatment target. So a few different strategies from DBT. DBT has some helpful stuff to pull in. There's also the safety planning intervention, which can be a one session or part of one session intervention. And then the CAMS, which stands for the Collaborative Assessment and Management of Suicide, which is a outpatient or can be outpatient suicide specific, and it focuses on developing other means of coping and targeting drivers of suicide risk. So I intended at least to put these kind of in order of where I might go to with a person. So including Lori, who I mentioned before. So as an example for the recent time she started preparing to end her life by overdose, which is her typical method that she thinks about when she's feeling more suicidal and a lot of despair. So I pull from the DBT's functional analysis strategy. So basically, this is just like a really detailed description of what happened prior to the last time you started acting, or you made an attempt, or you injured yourself. It's like for any target behavior or experience. There are forms for this, which I have used before, but more commonly when I'm doing it, I'm just doing it out loud and discussing the series of events with people. The idea is, I remember a prior supervisor describing, like, you want enough detail so that if you wanted to like act it out, you could do that. You want to really thoroughly understand all the steps of like what happened, what this person was thinking and feeling, what did they start doing, etc. And there's multiple purposes for this. So gathering information, building a shared conceptualization between the client and the therapist. You're also, by discussing it, increasing the client's awareness and memory of what their series of events is before instances like this. You're trying to identify areas for learning and practicing skills. It also can work as a diffusion exercise. To pull in an ACT term is like being able to like step back and like observe and think about like what happened. Sometimes it can be like going through these events in detail. It can be an aversive consequence for like things like cutting, for instance. It's like sometimes people come in and they don't want to talk about it. They want to talk about other things. I also would love to talk about other things, but since if a person is injuring themselves or preparing to die, that's the highest priority of things to talk about, because it's not possible to do therapy with folks that are in the hospital or are no longer alive. So we need to like focus on life first, and then other things. So multiple purposes of FAs. Here's a couple of worksheets that exist. If anyone had the urge to have them, like they're often searchable online, or feel free to email me. There's a ton of them. Some of them are just like a list of overwhelming, lots of words, a list of questions. Some of them kind of show a series of events, but you're trying to gather information about like a prompting event, vulnerability factors, thoughts, emotions, urges, etc. And then the person's behaviors like in detail. Let's see. Sorry, that was a repetitive slide. Oh, shoot. I tried to add this as a picture and I was unsuccessful. I'm having the urge to, I'm curious how many people have seen the safety planning intervention before. I'm going to share the actual document so that you can actually read it. It's like, I'm guessing a good number of people have. It's probably, there's a lot, if you do a Google search for this, you can find different versions of it. This is probably one of my favorite versions. If you have any client that has been to the hospital, they likely have a version of this, often a more abbreviated than this one. But the idea is that you are going through in like an organized, written down fashion, the person's plan for safety. So includes stuff like triggers and stressors that are common for this person, warning signs that a crisis might be developing, internal coping strategies, so things that you can do on your own without other people. So these can be distraction, etc. Strengths to remind yourself of. And then people that can either provide distractions, so get your mind off of it, or people that can like talk you through it / like help you and discuss the actual concern you're having, and specific contact information, ways to make your environment safe, so like remove guns, like lock away knives and pills, etc., and something worth living for. So I like this version because it has kind of more aspects than some others that I've seen, but this is a version of the safety planning intervention. That's the one we use. Awesome. Cool. Let's see, I'm going to switch back to the PowerPoint. So that's a safety planning intervention. Next, I'm going to hopefully show you or discuss the CAMs a little bit more. I'm curious how many people have actually heard of the CAMs as an intervention. I'm just realizing that I didn't bother putting this in there. Awesome. So like a little bit of hands. Also better to share this one in the context of my actual worksheet. All right. So the CAMs, you can use it as a one session like intervention, but it's also the full manual of the CAMs includes follow-up sessions as well. It didn't share, hopefully this will. So the first form for the first session, hopefully people actually see this, something that says suicide status form.
Yes.
Okay, thank you. Great. So I really like aspects of the CAMs, and I've used it several times before. I've only used it for people that I'm like very worried about. It's something that I find really helpful, especially sometimes people that are having a lot of trouble like offering details about their experience, like when I just ask questions out loud. So the idea behind the CAMs is it's supposed to be like it's a form that you fill out together. And theoretically, if you're in person with folks, you're supposed to be like sitting next to each other and like looking at the form together and filling it out together. The first page here, you actually have the client fill it out, like they write down their answers, like as you like describe what it's looking for here. And it goes through things that can be contributing to suicidality for this person. So like psychological pain, stress, agitation, hopelessness, and self-hatred. And the person is describing those like aspects to you. And then you're supposed to rank them as how much each of these is contributing to your desire to die in this moment. And it's I found it like really helpful to go through this with some people. Is like sometimes folks are really struggle to offer when they're really in moments of distress, offer some of these details. And then it also asks like how much your thoughts are related to thoughts about yourself versus thoughts about other people. It asks you to rate your own, like currently your impressions of how likely it is for you that you will kill yourself. And then it goes through your reasons for living and reasons for dying, and has you rate both how much you want to live and how much you want to die, and tries to narrow, like think about one thing that would help you no longer feel suicidal or feel less suicidal. The second page of this, which typically by the time I've done this, like the first part with people, I've already gone through this with people. But theoretically, you can do both of these things in one session. Let's say you have a client that comes in and you don't know this information, or it's earlier on when you're meeting with them. This part of the form is supposed to be the part that the clinician fills out while the client is answering, and you're kind of writing so that they can see and going through this together. So as you can see, it goes through all sorts of things that are relevant relevant to harm history. And then it has folks identify at least one, but can be several like treatment targets or like problem targets. I'm gonna stop sharing that part for the moment and go back to the slides. I tried to put these into my PowerPoint, but it ended up being too small to actually read anything. So apologies for the flipping back and forth. Curious if people have any reactions to either the SPI or the CAMs. Possibly a lot of reactions. I'm like gonna skim back.
Yeah, a couple of things in the chat.
Yeah. Yes. So it sounds like some new additions of the CAMs and like a youth version. And folks saying that they like it. I agree that I would not use this for people that like occasionally think of dying or like even like daily think of dying, but are like not particularly likely to act on it in various ways. So this would be somebody like this is something I'm quite worried about, and this is my main target of treatment right now. That would be the folks, and also people like I've had some folks that when they get really depressed, like they really struggle to say things. Like I've had kids that are just like covering their face with their hair and are like giving one-word answers and not sure how to describe their experiences. It's just like they're feeling so terrible right now. I found like for those folks sitting side by side, a lot of them have been able to fill out that form themselves. And it's like maybe it's something about like looking at it on paper and it's like less intense than like talking about it out loud. I've had some people that are really struggling to verbalize, like actually be able to fill out the form, which is super helpful. Awesome that there's CAMS training through DMH, love it. And some questions, it sounds like, for Margaret. Awesome. I will touch on quickly here a few things from DBT that I have found really helpful. So a few parts of this is like in the functional analysis, sometimes you identify a moment or several moments where the person's distress is going up, sometimes really quickly, and also in the CAMs, you're identifying like, you know, the distress indicators as being a contributing factor towards suicidality. So really commonly folks that are really struggling with intense suicidality, I go to the DBT distress tolerance module. I'm guessing a lot of folks have heard of DBT, but it's one of the CBT spin-offs that was developed for folks with really intense emotions and often harm risk related to that. And they do a really good job at more thoroughly having strategies for feelings than CBT does, in my opinion. So I find a lot of this helpful. There's a list of the distress tolerance skills here. This one is pulled from the DBT for Adolescents manual, which I actually use more often. And it has, so I put in a couple of the forms, which might be slightly small for reading, but so TIP is one that I commonly start with. Now I often tell people, like, you know, when if we imagine our distress level as being from 0, where you're like almost asleep, you're so calm, up to 10, which is like the most upset you can imagine being. Like the TIP strategies are really good for high numbers, so like 9, 10, etc. It includes temperature, so it's like you immerse your face and temples into cold water and hold your breath for 30 seconds. It's a way of calming down your physiology quickly. Intense exercise like burpees. And then the 2 Ps are paired muscle relaxation and pace breathing. So that's one I often go through with folks. And then The next one after that is typically distraction. I found that some coping skills are harder to access when you're at high levels of distress. So tip and distraction is typically where I start. And so this describes different distraction strategies. And then based on how those go, you can add to them, etc. But I find going through a few of the DBT skills is really good for the distress part of usually the work up towards suicide attempts. So thinking quickly about Lori, and then I can check on questions again. We have like, it's one of my questions I ask her every session, is how much she's been thinking about death or dying. Some weeks it's not there at all, or like there.
Excuse interruption. Can you teach us?
Sorry, I couldn't tell if that was a question or maybe a unmute accident. I'm happy to answer a question. Let's see. When she starts to get more distressed, typically her parents pick up on it, because we've done the safety planning intervention. We drafted it and we've reviewed it a couple times in session. And so Lori and her family are all pretty aware of the signs she's starting to struggle more. And when that starts happening, the parents remove means. So they lock up sharps, even though Lori hasn't really thought about dying by cutting. She mostly thinks about overdose. So her family locks up all pills that could cause notable harm. So when she took pills, the one time she took pills, it was like she didn't have access to anything that would actually cause her to die. It's still very relevant because she took pills with the desire to die. So I would still count that as a suicide attempt, even though it did not result in any like medical harm to her. We also have identified like her typical main reasons for living are like how much she knows, in part of her mind, she knows how distressed her family and siblings would be. They've made that very clear to her, and occasionally when she's particularly distressed, she's feeling so much like a burden and so hated by the world that kind of takes over. But usually that isn't enough to result in her choosing to live. We've also discussed like strategies that she's used in the moment that have worked and not. Whenever she has an instance of increased SI, we've talked about like in detail what has happened beforehand. So we have a better handle of what things are particularly difficult for her to manage. These are what we've kind of consider it as the drivers. So intensity of sadness. So it gets intolerable. She gets desperate for it to stop, feeling like a burden or that people dislike her. And then in those contexts, although she has hallucinations outside of these moments when she's particularly distressed, the voices saying that she should die are a lot more convincing. And then she starts agreeing with them. And so kind of the combination of those things has been common when her suicidality increases. And I'll put a note on like some challenges and questions kind of for Lori, and we can talk about that or anything else you want to talk about. So I've had some challenges ranging for Lori to complete homework or practice skills. And so that's why we've pulled parents in a bit more, is like they're there. And Lori's pretty open with her family and willing. And so the family is more likely to help remind her. I would love to increase her ability to think of these strategies herself. But when she's very distressed, it's very hard for her. She also had some trouble remembering details of these moments when she's calmer, like in session. It's hard for her to remember. So like the functional analysis sometimes has gaps. And then she is very infused or like very aligned with thoughts and beliefs about herself that are negative, and negative thoughts about how people perceive her. It's been tough to shift those. So I will pause now and see. It looks like there's some chat about the CAMS trading. And Awesome, cool. Yeah, and I kind of rewinding back, I know there was an earlier question about like folks that have made an attempt or gotten close to it in between session. And this is kind of an example of that, is like if I have a person who is like actively working with me to understand what happened and plan things that can go differently in the future and planning for safety, I am very unlikely to recommend hospitalization. With Lori and her family, we have talked about several times like what would be like the situations where we would want to go to the hospital. She has actually gone to the hospital before once. It's like before I started working with her in the context of suicidal ideation. She hadn't made an attempt. So, and really found it highly unpleasant. So they really don't want to go back. But it's sometimes a motivator is like to try other things. As like, I really don't want to go back there, understandably. But yeah, even folks that have made more intense attempts in between sessions and are behaving like this in session, in some direction, and I think that there's a good chance that we can make it to the next time I see you without attempts, that I'm fairly willing to try it. I really want people to remain alive, and that makes me quite worried sometimes, but it's like I don't weigh my own anxiety worry above like what's probably effective. And a lot of times I don't find it effective to go to the hospital when like this is kind of the pattern. So hopefully that helps a bit with that question. And it is anxiety provoking, certainly. So this is where it's like checking your decision making with others, like describing that you're worried with others, seeing if other people involved in care with this person specifically would make a similar decision. I think that helps. And yeah, maybe I'll shut up for a second and see if see if other folks have questions that you wanted to ask.
Well, and I wanted to thank you, Michelle. I wanted to call out a question in the chat, and apologies if you've touched on this a bit already, but around so for a client who has a history of suicide attempts, but now what they mainly struggle with is rumination and kind of compulsive thoughts, talking about like bringing up the word suicide in a session, then causing kind of a rumination spiral. How would you recommend having those discussions in that case?
Yeah, that's a good question. Maybe I might unshare the screen so I can see y'all a little bit better. I'm happy to go back to anything though. I still have the slides up, but yeah, that's a great question. And it is interesting sometimes, like thinking about whether somebody's thoughts about death and dying are rumination versus obsessions versus whether they are not. I think how I've been taught to distinguish those two things, and I will say it can be both, but how mostly like distinguishing those things is are the thoughts linked to how you're feeling? Is like if you're feeling distressed, then I would say that they are like you feel distressed and then you starting to have thoughts of death and dying or thoughts of harming yourself, then I would put them more as not rumination necessarily, but they're like harm risk to target. Like, yeah, if you have a person that thinks a lot about suicide and like it's finding reminders in the environment, like makes them think about it, and you're feeling inclined as a therapist, so it's like I have to avoid all words that sound like harm risk because this person might go into a spiral, then that would, this is probably a full conversation for another time, I would be going towards OCD therapy strategies. And you would want to review that in detail with the client and like see what they're willing to try. But the idea behind that is like you're not going to be able to avoid, especially in our society today, like you're not going to be able to avoid triggers for thinking about death and dying in our world, unless you are like in your room, not in social media at all, and not talking to anyone. So if we're going down the path of like we need to avoid all triggers, then it's probably going to be necessary to do something in the like OCD direction. And usually this, like when I've gone there, when we've tried lots of other things already, it's like we've gone through the distress tolerance, not with Lori, but I actually have another client. Like Lori's self-harm I thought are really related to distress and feeling depressed. But I have another client who has a lot of these thoughts that are not, like they are sometimes and they're not other times. And like talking about, let's see, living with, yeah. It sounds like there's some suggestions in the chat about like groups. I agree with that. Is I think another thing that can come up is like, just like with anything that's like a rumination, like intrusive thought sort of thing, people like try to start like controlling the thought and like shutting it down. And if I have this thought, it's like super bad. And what does this mean about me? Rather than going the direction of like, my brain does this thing where it has this thought, and allowing it to exist, or intentionally like doing exposure, like diffusion strategies with that. I think the ACT direction is really helpful with this sort of thought. Like trying that sort of thing out can be really helpful. And also normalizing. It's sometimes folks might like have the experience that there's something wrong with me if I think about this thought, is like having thoughts of dying mean that like you shouldn't be functioning in this world. I really strongly challenge that, as like a lot of people, regardless of whether they're in treatment or not, think about death and dying sometimes pretty often, and folks would never particularly know. And so I think that normalizing that is really helpful, and kind of considering like, one, is this helpful to think about or not for you? One, and two, like, what does it mean or signal when you're having this thought? Sometimes it's like, I really hate what I'm doing right now and I would like to escape. Sometimes it's other sorts of things, but yeah.
And I'll just say, I appreciate, so basically what you're saying is then the rumination is the kind of clinical target that you're working with that person on. And I know you said that could be a whole talk. We actually have had a talk about the overlap of OCD and psychosis.
Right.
So I will throw a link to that in the chat.
Yeah, that's very common overlap as well, definitely, for sure. And again, like a lot of times these things overlap in, messy, complicated sort of ways. And you can have flavors of multiple like clinical considerations for sure. I did notice a comment. A comment in the chat from Dr. Keshavan. Dr. Keshavan, I feel like possibly you're more qualified to comment on psychopharmacology for suicidality than I am. How my impression is things in the direction of antidepressants. However, like SSRIs, I would defer to the psychiatry experts like yourself on that one.
Yeah, so thanks, Michelle. No, wonderful talk. SSRIs are controversial because there is literature that they may actually trigger suicidality in some people, but help in others, and so on. But what is known, and there is evidence based for, is clozapine has an anti-suicide effect, and so does having an anti-suicide effect. So, given there are likely to be patients with psychosis who have chronic suicidality, it's worth considering whether these interventions have been considered in those people.
Yeah.
The other thing I want to say is, in terms of the assessment, I use a mnemonic that I use myself as to what are the key factors to think about, and that is the 4 M's. That is motivation, method, and the presence or absence of mental illness. And there's one more. I'll tell you when it comes back to me.
I was like, yeah. I know you have a mnemonic for this.
Yes.
I wonder if there's a thing in the world that you don't have a mnemonic for, Dr.
Yeah. I'll put that in the chat if I remember. Yeah.
Sounds good. I often also encode things better when I see them written down. Yeah, that's helpful. I know for Lori, in this situation, for her, both psychosis and depression symptoms are really part of her process towards becoming more suicidal. So she's on both an antidepressant, she's on Wellbutrin, and an antipsychotic medication. I am currently not remembering which is the current one, but I know she's on both. I am curious, so I know of the concern about antidepressants triggering or worsening suicidality for some folks. I've gotten the impression that there's like more recently, there's been a lot of challenge to that concern. I'm curious if you could comment on that.
Yes, there is large-scale data do not support the earlier observation that suicidal behavior increases after SSRIs. The larger studies and epidemiological studies of people on versus not on antidepressants suggest that suicidal behavior is higher in those who are not on antidepressants. So that initial concern is to some extent mitigated by this more recent literature.
Yeah, that makes sense. Yeah, that's helpful. Yeah, that's consistent with I've like heard comments from doctors recently. And of course, like a lot of families or young people will come in like concerned about antidepressants based on having heard this. And I know it's still typically part of the informed consent for starting.
Yeah, so the way, clinically I think about it is there are some patients who are so depressed that they are, first of all, having the suicidal ideations. And secondly, they just don't have the motivation to get up and do anything about their suicidal ideation. So if you give an antidepressant, and if it improves the energy and the motivation before it improves the suicidal ideation, you get into a time point where they have more energy and the suicidal ideas have not gone away.
Mm-hmm. Yeah.
So it may be an initial concern. So probably a close monitoring during the initial few days before the antidepressant effects fully kick in would be the important thing to do.
Yeah, that makes sense. Thank you. I did also want to mention quickly, I knew there was one comment about self-harm that that I hadn't made it to mentioning, and somebody had mentioned, I can't remember phrasing, but that either cutting or something in the direction of cutting, like knowing people that do use cutting as a method of suicide. That's very true. And for a lot of the self-harm methods, it can be there's a lot of overlap, right? It's like you might talk to people in your like functional analysis review, and the person might say like, I did this, and like in the moment, like it made me feel better, and I wish that I would die. And so it might be like a combination of intent. So like sometimes people like, part of me wanted to die and part of me didn't. Sometimes that's like fairly common, and it's useful to just like know and like think about what sorts of things a person was experiencing in the moment, and like what their thoughts and intent was, and like what they had wanted to happen, and picturing and etc., like what they were feeling. But I fully agree that we attempt to use terms to be clear, and humans are very messy. Yes. So I appreciate that comment. If I said that, I certainly did not mean that cutting is not a method of dying. It certainly is. I will also say a lot of people will also cut like not wanting to die, and will describe that they wanted to feel better, or they were trying to find a physical way of expressing their emotional pain, or they couldn't handle, like a lot of people like feel emotions very physically intensely. It's like they couldn't tolerate the experience they were having right now, and they needed it to stop desperately, and they know that cutting will stop it, but they didn't intend to die. So I wanted to mention that both of those certainly can be possible. And I know we're close to out of time, but I think time for one more question / thought. Sarah?
Yeah, I don't know how like relevant this is to what we're talking about, so I'm kind of like curious what people think, but off of just like hearing about like ketamine and other dissociative drug treatments for like complex PTSD or even like alcoholism, which is interesting to me, or like other kind of complex diagnoses. I think like this is proven to like work, and I don't know, in my community I see most of my peers having a lot of like kind of gray area around what to do with that becoming more like common maybe. And I'd be curious to see the data, even that sounds really messed up, but of how many people relapse because of this this kind of newer treatment, because I've known the numbers are getting higher, like my friends or my peers or people in my community like going back to what they were using before because of even though the ketamine treatment helped, it then led them back to what they were doing before. So I'm not sure if I like leached on to something that was sort of just a minor part of what we were talking about, but I think it feels pretty like this like weird cycle that I hope clinicians would stay really in tune to, with like newer treatments that become like legal, and then the complexities of like escapism and addiction that like I do believe lie in every person who is trying to die or is resistant to treatment in some way. And then there's this compelling nature of like a ketamine treatment, even though it's also proven to help. It's like it feels so dicey to me, but I think we're like in the middle of it right now.
Yeah.
So I just wanted to share that.
Yeah, you're right. There's like a variety of newer treatments or kind of thoughts about treatments. I feel like we could spend a whole chunk of time talking about that one. One, it makes sense that people, want to avoid feeling distressed. You mentioned the word escapism. I was like, that's very human for sure. My impression of the ketamine research is that it's a bit on the newer side. And typically that means that the research is currently looking at like a narrow group of people. And so I would imagine that a lot of the studies are ruling out a lot of the human complexity that is probably what most of us are seeing and working with in clinical practice. So like ruling out folks with psychosis, ruling out folks with substance use histories, and are trying to look mostly at whatever clean, like depression, for instance, and see if it is helpful. And yeah, I do think that it is really important to be striving to learn how new treatments impact a broader range of folks, and also like the longer term consequences we might not be intending. So like whether folks relapse after trying treatments, for instance. Yeah. I appreciate, I was like, I always like to at least strive to end a couple minutes early for people's time, but I thank you for inviting me, and hopefully this was helpful, and happy Friday, all.
Yeah, thank you everyone so much. Thank you, Michelle. I know Lola posted the post-event survey in the chat, so please go and fill that out. And then you'll all get an email with the recording and the slides once they're available. But yeah, really great discussion, conversation, questions. I really appreciate it.
Thanks so much.
Great. Thanks everyone.
Bye.